Welcome back, guys. Now in this part 2 of twin pregnancy, let's discuss about the complications of twin pregnancy and let's see how we will deliver the twins. Now we are going to discuss about the complications in 3 parts. Like first, let's discuss about the placental complications, maternal complications and fetal complications. Later on we will discuss about the delivery. Now let's talk about the placental complications. Guys, having a twin pregnancy is a risk factor for placenta previa. Why? Two babies, two placentas. One placenta is going to lie in the upper uterine segment near the fundus and the other placenta will find its way into the lower uterine segment. Having a placenta in lower uterine segment is called as placenta previa. So, multifetal gestation or twin pregnancy is a risk factor for placenta previa. True. Now, two babies are there in the uterus. Do you think that these two babies are going to simply sit together? No, they are going to fight. So, they are going to create a lot of mess inside the uterus. In that mess or during that fight between the twins, there is a chance that the placenta can be separated. This is known as placental abruption. So, placental abruption can be seen with the twin pregnancies, and during this fight, there is a chance that the membranes got ruptured. This is known as premature rupture of membranes. So, twin pregnancy is a risk factor for premature rupture of membranes. And also remember that there can be cord entanglement by the babies. Okay, the cord of one baby can be entangled by the other baby. So, cord entanglement can happen. Now, please take this note. Because of the increased placental size, twin pregnancies, two placentas. Two placentas means big placenta, more placental tissues. This more placental tissues is going to make more hormones. One such hormone is beta HCG. If there is more beta HCG in the mother, we all know that beta HCG is the one causing vomiting during pregnancy. More beta HCG means more vomitings. More vomiting means hyperemesis gravidarum. Why there is hyperemesis gravidarum? Because too much amount of beta HCG. Hyperemesis gravidarum can be seen in twin pregnancy. True. Because of the increased production of human placental lactogen, we all know that human placental lactogen is the one which is getting produced from the placenta. More placenta, more human placental lactogen. What is the function of human placental lactogen? Human placental lactogen is the one which is responsible for insulin resistance. Okay. Human placental lactogen is the one which is responsible for insulin resistance. More HPL, more insulin resistance. If there is more insulin resistance, there is a chance of gestational diabetes mellitus in this female. Okay, so placental complications we have discussed. Now let's discuss about the maternal complications. See, these maternal complications I am dividing into antepartum maternal complications because of twins and intra and postpartum maternal complications. Now let's discuss about the antepartum complications first. Antepartum means before delivery. Okay, before delivery, what kind of problems can happen in a mother because of twins? There can be hyperemesis gravidarum, we have seen, because of so much amount of beta HCG, hyperemesis gravidarum can happen. Polyhydramnios can be there. Okay, two babies making so much amount of liquor, so polyhydramnios can happen. Okay, normal pregnancy, normal fluid. Two pregnancies, too much fluid, polyhydramnios can happen. Yes, true. One pregnancy itself is a headache. So actually with one pregnancy itself you can have a preeclampsia. Two pregnancies, more headache, more BP. Okay, so there is a risk of preeclampsia. Actually, normal pregnancy itself, we know that there is physiological hemodilution. Okay, physiological anemia will be seen with the normal pregnancy itself. Two babies, more the problem. So anemia can happen. Antepartum hemorrhage can be seen. Why? Because two placentas can be a risk factor for placenta previa, abruptio placenta. Both of them can cause antepartum hemorrhage. True. And there can be pressure symptoms. Okay, pressure symptoms can be there. Why? Because two babies, more distended the fundus will be. Okay, the uterus is going to distend more, the uterus is going to raise more. So it compresses the diaphragm. So that diaphragm is getting compressed. Lungs are getting compressed. That causes dyspnea. Okay, so these are the pressure symptoms and there can be a chance of a preterm labor. Okay, all these are the maternal complications. Guys, I am repeating, I know I am repeating because these are your exam questions. All of the following are complications because of twin pregnancy except hyperemesis, polyhydramnios will be there, preeclampsia, anemia, antepartum hemorrhage, preterm labor, placenta previa, abruptio placenta leading to antepartum hemorrhage. All of them are going to be complications. True. Now, if you look at the intrapartum and postpartum complications, malpresentations can happen. Just two twins, they can't present properly. Okay, the delivery is not going to be easy with the twins. There can be malpresentations. Malpresentations are seen during delivery, intrapartum complication. There can be postpartum hemorrhage, postpartum complication. After delivery, there is a risk of so much amount of hemorrhage. That is postpartum hemorrhage. Why there is postpartum hemorrhage, guys? Why? Because twin pregnancy means uterus is distended so much for 9 months. Now it lost its elastic recoil. Uterus was over distended. Over distended uterus cannot contract properly. When uterus is not contracting properly, that is known as atonic uterus. Atonic uterus will cause postpartum hemorrhage. Primary postpartum hemorrhage. In the topic of postpartum hemorrhage, we have already discussed that uterine atonicity will cause primary postpartum hemorrhage, and there is a chance that there will be a retained placenta. Okay, there is this very big placenta, all that placenta is not properly getting separated, so there can be a chance of retained placenta, and this retained placenta will cause again postpartum hemorrhage. And as there is true twins, there is increased chances for the operative delivery. Either you have to apply vacuum or forceps. Okay, so these are the maternal complications. After maternal complications, let's discuss about the fetal complications. The most important fetal complication is a prematurity. Twins can cause premature rupture of membranes that can lead to preterm labor, preterm delivery. True. So instead of delivering at 37-38 weeks, now the fetus is getting delivered by 34 weeks. A risk of prematurity will be there. Okay, actually we have discussed in twin pregnancies, especially if it is a monochorionic twins. Okay, monochorionic diamniotic twins are getting delivered by 34 to 37 weeks. Monochorionic monoamniotic twins are getting delivered by 34 weeks. If you are delivering a twin by 34 weeks, do you expect that this baby was fully developed? No. So there is a risk of prematurity, and there is a risk of intrauterine growth restriction. Okay, baby is not properly growing in that uterus because there is one competent baby is there. Okay, there is no proper nutrition, and intrauterine growth restriction can happen. True. A twin-to-twin transfusion syndrome can happen. We will discuss why this twin-to-twin transfusion syndrome happens in the later part of the video. But for now, trust me, there is a risk of twin-to-twin transfusion syndrome, especially with the monochorionic twins. Okay. Now, monoamniotic placentas can be seen. These are bad placentas, right? Yes. Conjoined twins can be a risk factor. Single fetal demise, cord entanglement, all of them are the antepartum complications seen with the fetus. Cord entanglement, single fetus can be died, there can be conjoined twins, all of them are the risk factors. But during delivery and after delivery, what are the risk factors? During delivery, there can be premature rupture of the membranes, interlocking of twins can happen, and cord prolapse can happen. Important MCQs. Okay. Now, after fetal complications, let's discuss about a twin-to-twin transfusion syndrome. There is one twin, other twin. Please concentrate here. Twin number 1, twin number 2. See what exactly is this twin-to-twin transfusion syndrome? Blood of one fetus or blood of one twin is going to other twin. So one twin is acting like a donor and the other twin is acting like a recipient. For example, in this image, please concentrate. The twin 2, okay, or the twin B, okay, let me write it as B, okay, let me write it here. This is the twin B. Now, this twin B is comparatively small in size when compared to twin A. Why? Because this baby is giving the blood to the other baby. So, twin B is a donor and twin A is a recipient twin. So why this is happening? This is happening because vascular anastomosis, a deep vascular anastomosis. What kind of anastomosis? Arteriovenous anastomosis, most common type. What exactly I mean by? See, the artery, okay, the artery of one baby, okay, the artery of this B baby is in connection, abnormally getting connected to the veins of the recipient baby. So whenever such vascular malformation happened, whenever such abnormal anastomosis happened between the blood vessels of two twins, what happens? See, here in the artery there is high blood pressure and in the veins there is low blood pressure. Because of this reason, blood is moving from twin B to twin A. Okay, so donor twin to recipient twin, blood is moving. What happens? As one baby is getting so much amount of blood, it is growing bigger, it is growing larger. As one baby is continuously donating blood, one baby will be having growth restriction or growth retardation. Which baby is going to die? Both the babies are going to die, because one baby is going to receive so much amount of blood, there will be circulatory overload, cardiac failure. The other baby is going to die with anemia. Okay, so at the end of the day, both babies will die. Now, what exactly is twin transfusion syndrome, guys? Twin transfusion syndrome is due to abnormal vascular anastomosis, and such a deep vascular anastomosis is seen between artery and a vein. Remember, such kind of abnormal anastomosis can be seen between artery and artery. It can be seen between vein and vein also. But there won't be a big problem. Why? Because if there is a artery anastomosis, there won't be a big problem because same pressures will be there. Blood is not going to move from unidirectionally from one baby to other baby. But if there is arteriovenous anastomosis, then only blood is going to move from artery to the vein. That will cause a problem. That is twin transfusion syndrome. In between the twins, there is transfusion of the blood. Now, see, there is a unidirectional blood flow from the donor twin to recipient twin. Donor twin is going to be growth restricted. Recipient twin is going to be very bigger in size, larger in size. Okay. Now, see, especially this kind of twin transfusion syndrome definitely is going to be seen with the monochorionic placentas. No doubt that monochorionic pregnancies are going to be more complicated than dichorionic pregnancies. That too, this twin transfusion syndrome is seen with monochorionic diamniotic twins than monochorionic monoamniotic twins. There are two types of monochorionic placentation: monochorionic diamniotic, monochorionic monoamniotic. This twin transfusion syndrome is mostly seen with monochorionic diamniotic twins. Okay, and remember, in monochorionic monoamniotic twins, what kind of vascular anastomosis can happen? There is arterial anastomosis, which is not a big complication. Okay, if arteries are getting mixed, means not a big problem because the pressures will be same, so that there is no unidirectional blood flow. Okay, now after this, let's see what are the features of the donor twin and what are the features of the recipient twin. Donor twin is going to be anemic. Yes, it is giving all the blood, so it becomes anemic. And the recipient twin, it is growing larger and larger in size because it is receiving so much amount of blood. So much amount of blood means polycythemic. Okay, now the donor twin is going to suffer with oligohydramnios. Even in this image, you can clearly see the pocket, the amniotic pocket is very smaller. But on the other hand, the amniotic cavity is going to be very larger. Why? Because in a donor twin, it is completely giving all its blood. Whenever it is completely giving all its blood, its blood volume is going to decrease. Whenever its blood volume decreases, automatically glomerular filtration rate, urine production by the twin automatically decreases. So, donor twin will suffer with oligohydramnios. Why? Because it's not having enough fluid in the body. Whenever there is no enough fluid, it is not going to urinate. If it is not urinating, oligouria. Okay, if it is not urinating, the amniotic fluid levels will come down. Why? Because amniotic fluid is nothing but the fetal urine. Whenever there is oligouria, automatically there will be oligohydramnios in the donor twin. And this twin, as it's giving all its blood, it is growth restricted. And on the other side, recipient twin is going to have polyhydramnios. It's going to be large in size and it's going to produce lots and lots of urine. Why? Because it's have a lot of fluid in the body. Lot of blood is coming to the baby. So more blood supply to the kidneys. More blood supply to the kidneys means more GFR. More GFR means more urine production. More urine production means polyuria. Okay. Now after this, let's talk about the diagnosis in twin transfusion syndrome. See, there will be hemoglobin difference of more than 5 grams between the twins. See, we have to take larger twin as the index. Very important MCQ. Index is a larger twin. Okay, larger twin is taken as an index. In comparison to larger twin, the smaller twin will have less hemoglobin. If the difference between the two twins is more than 5 grams, you are now diagnosing that this is twin transfusion syndrome. One baby is having lot of hemoglobin, other baby is having very less hemoglobin. The difference between the two twins is more than 5 grams per DL. Okay. Now, weight difference. The weight difference between the two twins is more than 20%. Yes, it can also be used for the diagnosis. Now, if you perform ultrasonography, okay, there you can see that the type of placentation, the type of chorionicity is going to be monochorionic diamniotic type of placentation. If you look at the amniotic fluid pockets, Leica pockets, see the donor twin is going to have a very small amniotic cavity. Okay, the length of the amniotic cavity is going to be less than 2 centimeters. Less than 2 centimeters means it is oligohydramnios. So a donor twin is going to have oligohydramnios, and a recipient twin, if you look at the Leica pocket, the Leica pocket will be more than 8 centimeters. Okay, 8 centimeters means it is indicating that polyhydramnios is seen. Okay, see, these are the ultrasonographic pictures. Apart from this, also by doing Doppler, you can see the arteriovenous anastomosis. Okay, by looking at the Doppler, you can know where exactly is the arteriovenous anastomosis. If you look at the arteriovenous anastomosis, definitely this is twin transfusion syndrome. And also remember that the middle cerebral artery peak systolic velocity, okay, the velocity with which blood is flowing through middle cerebral artery in a donor twin will be more than 1.5 multiples of median. Okay, what exactly I am trying to put into your mind, guys? This is a very important concept. See, if I am talking about a donor twin means it is giving all its blood. If it is giving all its blood, what happens to the blood supply to the brain? Blood supply have to decrease, but it shouldn't happen. The brain is the most vital organ, right? So this baby is trying to preserve its cerebral circulation. How it is trying to preserve its cerebral circulation? The baby's heart is going to beat faster, and this baby is trying to maintain the cerebral blood flow, increasing. See, it's going to decrease the blood flow to all the peripheral organs, but it maintains the blood flow at least to the brain. So donor, if you look at the donor twin, the middle cerebral artery peak systolic velocity will be more. Much amount of blood is now being directed towards the cerebral vasculature. So more than 1.5 multiples of the median. With the normal median value, okay, when you compare with the normal median value, now it will be 1.5 times more. And if you look at the recipient twin, it's already receiving lots of blood. Now what happens? Now it's not going to increase the blood supply to the cerebral vasculature. So the value will be, okay, so PSV value, the peak systolic velocity value will be less than 1 multiples of the median. Okay, these are all the things which can be used for diagnosis of the twin transfusion syndrome. Okay, let me recap. If you look at the difference between the hemoglobin values, more than 5 grams per DL, indicating that this is a condition of twin transfusion syndrome. Weight difference between the two twins, more than 20%. Think about twin transfusion syndrome. If you look at the Doppler, if you look at the arteriovenous anastomosis, twin transfusion syndrome. And if you do ultrasonography, in ultrasonography, one baby is having polyhydramnios, other baby is having oligohydramnios. Oligohydramnios is seen in the donor and polyhydramnios is seen in the recipient twin. Okay, and also on ultrasonography, you can also see this monochorionic diamniotic type of placentation. Okay, so these are the diagnostic criteria. Now, let's see the Quintero staging for twin transfusion syndrome. Okay, what is this Quintero staging? In stage 1, please remember, it's not that complicated. In stage 1, what you can see is polyhydramnios in one baby and oligohydramnios in the other twin. Polyhydramnios is seen in the recipient and oligohydramnios is seen in the donor. Now, in stage 1, please remember, the urine is still visible on ultrasonography. Urine or urinary bladder. Urinary bladder is still visible in the donor's twin. Or urine is still visible. See, as time passes by, this condition is going to become more severe. What happens is, in donor's twin, when the staging is getting increased, the urinary bladder or the urine in the urinary bladder is not going to be seen on the ultrasonography. So that's what happened in the stage 2. In stage 2, urine is not visible in the donor's urinary bladder, or donor's urinary bladder is not going to be seen. In first stage, milder problem. One baby is with polyhydramnios, other baby is with oligohydramnios. Now in the stage 1, you can see the urinary bladder or the urine in the urinary bladder in the donor twin. It's still visible. But in the second stage, the urinary bladder is not visible in the donor twin, which means, see, there is oligouria or anuria. Okay, the condition is getting more severe. That donor is not producing the urine. Why? Because it's having such a very low blood volume, no urine production. Okay, so that's the reason why you can't able to pick up the urine in the urinary bladder. In stage 3, what's happening in stage 3, guys? See, criteria of stage 2 is there. Along with that, abnormal Doppler studies of the umbilical artery. Okay, abnormal Doppler studies. If you do Doppler, what you will be saying? Arteriovenous anastomosis can be seen. So abnormal Doppler studies can be seen in the umbilical artery. That's what is the stage 3. In stage 4, you can have hydrops. This is a very important point. Hydrops is seen in stage 4. Okay, baby is getting like so much swelled. And in stage 5, death of either of the fetuses. Any one fetus is dead. At the end of the day, both fetuses are at risk of dying. Okay, one baby will die with cardiac failure, other baby is going to die with a shock. Okay, circulatory collapse. One baby is going to die with anemia, other baby is going to die with circulatory overload. We have already discussed that. So stage 1, simple, polyhydramnios, oligohydramnios. Bladder is visible in the donor. In stage 2, bladder is not visible in the donor twin. Stage 3, abnormal Doppler findings will be seen. Stage 4, hydrops will be seen. In stage 5, death of either of the fetus. This is what is Quintero staging. Just remember, Quintero staging is done for twin transfusion syndrome. Now after this, let's look at the management. If I am talking about the management of twin transfusion syndrome, this syndrome is mainly because of the abnormal connection between artery and vein. Okay, that's the main problem. Abnormal connection is there between artery and vein. Now what you can do? You can simply ligate the abnormal connection. So laser ablation. Okay, so see, here is the artery, here is the vein. So you are simply ablating it with fetoscope. So fetoscopic, take the point, fetoscopic laser ablation is done for management of twin transfusion syndrome. And also you can do amnioreduction in the recipient. See, recipient is going to have too much amount of amniotic fluid. If there is too much amount of amniotic fluid, you can reduce the amniotic fluid, that is amnioreduction. See, this amnioreduction can be done with amniocentesis. You can take out that amniotic fluid. So, fetoscopic laser ablation or amnioreduction can be done. See, why this is very important? Because if you don't diagnose this condition, twin transfusion syndrome, in an appropriate time, there is 100% chance of mortality. Both the twins will die. Okay, you can lose both the twins. So take this point. See, twin transfusion syndrome, if it is present by or before 26 weeks, if you don't diagnose and treat it appropriately, okay, you have to do the fetoscopic laser ablation. If you don't do treatment in a proper time, there is 100% risk of mortality of both the twins. Okay, so this is the management of twin transfusion syndrome. Here you can see this is a one baby which is a donor, growth restricted, and there is this other baby which is a recipient who is going to receive a lot of amount of blood and it grows larger in size. And this baby is taken as a index baby, reference baby. Okay, now let's talk about TAPS. TAPS means twin anemia polycythemia sequence. Guys, remember, just wait. What exactly is TOPS? TOPS, TOPS. Twin oligohydramnios, polyhydramnios sequence. See, in twin transfusion syndrome, one baby is going to have a polyhydramnios, recipient baby. One baby is going to have oligohydramnios. Am I true or not? Yes. So, twin oligohydramnios and polyhydramnios sequence is seen in twin transfusion syndrome. True or not? Yes, absolutely seen. There is no doubt. But see, in same twin transfusion syndrome, one baby will be anemic. Yes, the baby who is a donor will become anemic and the baby who is a recipient will become polycythemic. That is known as TAPS, twin anemic polycythemic sequence. But here, please remember, there is no problem. There is no problem with the oligohydramnios or polyhydramnios. There is no oligohydramnios or polyhydramnios. Please concentrate. Only problem is anemia, polycythemia. But there is no evidence of polyhydramnios or oligohydramnios. Or there is no difference between the weight in both the babies. Actually, we know the weight of both the babies should be greater than the difference in the weight of the baby should be greater than 20%. Okay, to say it's a twin transfusion syndrome, the weight difference between both the babies should be more than 20%. And also we have discussed, like, one baby will be having polyhydramnios and the other baby will be having oligohydramnios. But in TAPS, all those things are not there. See, it's still twin transfusion syndrome, but there is no oligohydramnios, no polyhydramnios, no difference in the weight. Only problem is one baby is getting anemic, other baby is getting polycythemic. Weight is something almost normal, no big difference in the weight, and no oligo or polyhydramnios. Now, if you look at the middle cerebral artery peak systolic velocity, in the donor twin it will be more than 1.5 multiples of the median, and in a recipient twin it will be less than 1 multiples of the median. This is something normal, but there is no difference in the weight and no difference in the fluid volume. Okay, this is what we can see in the TAPS. Now, let's discuss about a condition called as a TRAP. TRAP means twin reversed arterial perfusion. Guys, please concentrate. Here is one baby, here is the other baby. But please look at the baby number 2. There is no development of the head and no development of the upper extremities. So, this is a twin pregnancy, but one twin is not developing the upper extremity. Why it is not developing upper extremity and what are the problems? We'll discuss. See, in this TRAP, one baby, okay, the baby whoever is not developing the head and the upper extremities, that baby is not having the heart. Okay, so there is this Acardiac twin. So very important point, in twin reversed arterial perfusion, one twin is going to be Acardiac. Okay, no heart is seen. Okay, well and good. Now what happens? See, the problem here in this TRAP is umbilical artery of a normal twin. Okay, umbilical artery which is having deoxygenated blood. Remember, the deoxygenated blood containing umbilical artery is in connection, is anastomosed with the artery of the other twin or the unhealthy twin. So, umbilical artery of normal twin which is carrying deoxygenated blood to the Acardiac twin. See, there is this arterial anastomosis. One baby is not at all having the heart. So, there is no such thing as pressure difference. So, umbilical artery of a normal twin is carrying deoxygenated blood to the Acardiac twin. So, what happens? All the blood is going to the Acardiac twin. See, as there is no heart in the Acardiac twin, the circulation cannot happen. What and all the blood is going, all this blood will be going to the lower extremities because of the gravity. All the blood is reaching the lower extremities. So lower extremities are developed, but the upper extremities are not developed. So this is a very important point. Blood only reaches the lower parts of the body of the Acardiac twin because of the gravity. It leads to failure of the upper part or the upper trunk to form and failure of the head to form. This is trap. Okay, acardiac twin. That's a very important point. Okay, now after this, let's talk about the delivery in the twin pregnancy. How we are going to deliver the twins? Very, very important slide. Please concentrate. Most of the time, 60% of the time, both the twins will be in the vertex position. That's it. Both twins are in vertex. Okay. Now, what to do if both the twins are in vertex? Do normal vaginal delivery. If both the twins are in vertex, it's very good that we can go with the normal vaginal delivery. Now, first twin is in vertex. Second twin is in breech. First twin is in vertex, second twin is in breech. Now what to do? See, remember, if first twin is in vertex position, cephalic position, you can go with the normal vaginal delivery. If first twin is in vertex position, normal vaginal delivery is possible. But other than vertex position, any other position, normal vaginal delivery is not possible. So it all depends on the vertex, it all depends on the position of the first twin. So remember, first twin is in vertex position, second twin is in breech position. So this can happen in 20% of the cases. Now what to do? Now what to do is, you can do normal vaginal delivery of the first twin. Okay, normal vaginal delivery can be done with the first twin. After that, for the second twin, you can do assisted breech delivery. Let's talk about the third condition. Please concentrate guys here. The first twin is in breech position. So if it is in breech, can you do normal vaginal delivery? No. If first twin is other than cephalic position, other than vertex position, we cannot do normal vaginal delivery. So first twin is in breech, normal vaginal delivery is not possible. Doesn't matter whatever the position of the second twin. Doesn't matter. If first twin is not in cephalic position, we will do only C-section. Okay. Now, if both the twins are in breech, simple, we will go with the C-section. Okay, so please concentrate here. I'm just summing it up. So both the twins are vertex. Most common position. Both twins are vertex. Very good. Normal vaginal delivery of both the twins. First twin is in vertex. Or first twin is in cephalic position. Good. We can try normal vaginal delivery. So do the normal vaginal delivery of first twin. Second twin is in breech. What we can do? We can do assisted breech delivery of the second twin. See, it's ultimately at the end of the day, it is normal vaginal delivery only. Normal vaginal delivery. Assisted breech delivery is also normal vaginal delivery. Okay. Now, first twin is in vertex and second twin is in transverse line. If first twin is in vertex, we can try normal vaginal delivery. Okay. So, I am doing normal vaginal delivery of first twin, and if second twin is in transverse line, what we can do? We will be doing internal podalic version. Okay, internal podalic version and breech extraction. Okay, very important. First twin vertex, normal vaginal delivery. Second twin is in transverse line, do internal podalic version and do breech extraction. Now, first twin is in breech. That's it. If first twin is not in cephalic position, answer is C-section only. It doesn't matter what is the position of the second child. What is the position of the second twin? First twin, not cephalic, C-section is the only option. Now both are in breech, C-section only. Okay, so this is how we are going to do the delivery in the twin pregnancy. We have completed all the important points. Hope the video is helpful. Thank you.